I'd like to thank the organisers for inviting me to challenge the statement that Class 1 and 3 antiarrhythmic should only be started as inpatient. I have no disclosures. The Vaughan Williams classification of the antiarrhythmic medications categorises them according to where they act on the cardiac action potential. Class 1 agents are sodium channel blockers, blocking the inward current of sodium, and they are classified into 3 groups, depending on their speed of action on the myocytes within the atrium, ventricle and Purkinje system. Class 3 antiarrhythmics are potassium channel blockers, blocking the outward current of potassium. Now, when you look at these drugs, there is good reason for Dr. Pass to feel smug and confident about winning the debate. To begin with, many of these drugs will be started as an inpatient by default, as they will be started for acute, intractable or recurrent arrhythmias, or else for arrhythmias in rare, unpredictable channelopathies. For example, lidocaine is only available as an intravenous infusion and usually reserved for intractable ventricular arrhythmias. Procainamide again is usually started in the acute situation for incessant or intractable arrhythmia, and it's actually not a drug we really use in the UK, and the oral version may be increasingly withdrawn from the market. Quinidine is rarely used in paediatric arrhythmias, but may be considered in patients with Brugada syndrome or sodium channelopathy or in short QT syndrome. Likewise, mexiletine is only likely to be used for selected patients such as those with long QT3. So of course these Class 1 antiarrhythmics should be started as inpatient, especially as the response to the drug is unpredictable. So that leaves us with the antiarrhythmics that can be given orally outside of the acute and unusual channelopathy situations. And they are flecainide and propafenone of the Class 1 agents and amiodarone and sotalol of the Class 3 agents. And of those, flecainide and sotalol would be the Class 1 and 3 oral antiarrhythmics we would most commonly use for SVT in children. Now, the question about whether to start antiarrhythmic therapy as an inpatient or outpatient actually goes back further than 25 years. Eric Pristovsky is a well-known figure in Heart Rhythm Society and runs a series of online talks entitled EP on EP, Eric Pristovsky on electrophysiology. And in 1994, so almost 30 years ago, he raised this very question about inpatient versus outpatient initiation of antiarrhythmic therapy for patients with SVT. And he observed that there are 2 primary reasons to initiate drug therapy in hospital. The first is to observe the effects of the antiarrhythmic agent on the arrhythmia being treated, and the second is to permit surveillance for adverse reactions to the drug. However, many patients with paroxysmal tachyarrhythmias do not have their arrhythmia during the initiation of drug therapy. So the only reason for monitoring is to detect proarrhythmia. But initiation as an inpatient makes the assumption that proarrhythmia will occur during the initial days of therapy when the patient is still an inpatient. So it's not helpful if time to proarrhythmia is days, weeks, or longer. There is no doubt that Class 1 and 3 antiarrhythmic drugs can be proarrhythmic. We all know of the CAST study, which tested the hypothesis that suppression of ventricular ectopics after myocardial infarction would reduce the incidence of sudden death. And 1,498 patients were randomised to receive either a Class 1 or antiarrhythmic flecainide or encainide or receive placebo. There was an excess of deaths in the patients treated with the Class 1 antiarrhythmics, and the CAST study made us all afraid of flecainide. In his paper in 1994, Eric Pristovsky described how he analysed 51 published reports of ventricular proarrhythmic events in patients treated for supraventricular tachycardia. and he found information on 162 patients. He noted that 96% of the patients who developed proarrhythmia had heart disease of varying etiologies, and that proarrhythmia occurred most commonly with quinidine. Well, we've already said that we wouldn't start quinidine as an outpatient in children. Proarrhythmia occurred in 9 patients with flecainide, but the information was scant about the timing, ranging from in-hospital to 8 months. There were 2 proarrhythmic events with propafenone at 10 days and 2 years, but not during initiation of the drug. Dr. Prostovsky concluded that the low frequency of proarrhythmia suggests that in-hospital initiation of therapy may not be cost-effective, and that for patients without structural heart disease, without sinus node dysfunction, and without prolonged QT interval, they do not need to be hospitalised for initiation of drug therapy unless the effect of the drug on the arrhythmia is important to observe. So almost 30 years after this paper, is this an approach that can be applied to children starting selected class 1 and class 3 antiarrhythmics? Well, Dr. Pass, of course, would say no, and he will want to scare you with multiple stories about proarrhythmia. He will probably want to remind you of Sodelow's proarrhythmic effects of bradycardia, prolongation of the QT interval, and most worryingly torsade de pointe, and of this recommendation that goes back 25 years that Sotalol should be started as an inpatient in children. And of course, any image of torsade is so scary that it will make you want to start Sotalol as an inpatient forever. Dr. Pass will want to tell you about frightening papers such as this case series of 3 infants prescribed flecainide for SVT. All 3 developed prolongation of the PR interval, prolongation of the QRS with right bundle branch block, QTC prolongation, and 1 even had variable AV block and VT. And here is the ECG at presentation in one of the patients with flecainide toxicity above and below after flecainide had been stopped. So again, frightening ECG changes. And indeed, the authors seem to support Dr. Pass by recommending that all children starting flecainide should have close monitoring, including serial ECGs and serum levels in the first 72 hours, and for infants under a year, it should be initiated as an inpatient with continuous ECG monitoring for 48 to 72 hours. However, what is important to note is that all 3 children did start flecainide as an inpatient, and all presented with toxicity after they had left hospital, 1 at day 25, 1 at 5 months, and 1 at 6 months. Also, one of the cases of toxicity was possibly related to drug overdose and the other to a change in milk intake. But what is important here is that starting flecainide as an inpatient was not helpful in either predicting or preventing future toxicity. Now, one initial review of this paper published in 2021 showing adverse events during initiation of sotalol and flecainide in children, it looks concerning. Flecainide resulted in prolongation of the QRS with dose reduction or discontinuation of the drug in 9% of patients. Sotalol resulted in prolongation of the QTC with dose reduction or discontinuation of the drug in 4% of patients, but most worryingly, 2 patients died with torsade. However, both patients who died with torsade had major heart disease and other comorbidities, and the authors actually acknowledge that the role of sotalol in the death of the 2 patients is not clear. In addition, 9 out of 11 of the patients who had dose reduction or discontinuation of sotalol had underlying heart disease. And although some patients had dose reduction or discontinuation because of QT prolongation with sotalol or QRS prolongation with flecainide, there were no arrhythmias with sotalol in patients with structurally normal hearts and no arrhythmias with flecainide in any patient. In fact, the authors concluded that the rate of adverse events during treatment initiation was low, although ECG changes can occur. That children with underlying heart disease seem to have increased risk of adverse events and rhythm-related side effects, but that consideration can be given to outpatient initiation of these antiarrhythmics in a select patient population with structurally normal hearts and normal function and without genetic abnormalities. Other studies support this. This study, investigating the safety and efficacy of high-dose sotalol in neonates and infants, showed a low incidence of adverse events, with no torsade, no proarrhythmia, no concerning bradycardia, no EV block, and only mild prolongation of the QT interval, and none greater than 500 milliseconds. And again, a low incidence of adverse events was also found in this study from Boston that aimed to determine the frequency of adverse events during sotalol initiation for arrhythmias in paediatric patients. The study was retrospective over 9.5 years and included all patients under the age of 21 years who started oral sotalol for the first time for any arrhythmia. And they assessed for adverse events including significant bradycardia while awake, new or worsening ventricular arrhythmia, significant QT prolongation, and conduction block. Now, of the 190 patients in the study, 3% had an adverse event, including 3 with bradycardia, but those 3 had no adverse clinical events. 2 had prolongation of the QT interval greater than 500 milliseconds, but no patient required emergency treatment, and all of the 5 patients who had an adverse event had congenital heart disease. There were no deaths or malignant arrhythmia in the series. This study would support the conclusion that sotalol could be started as an outpatient in selected patients. In the UK, it is quite normal practice for paediatric cardiologists to start flecainide as an outpatient in children with paroxysmal SVT who have structurally normal hearts and a normal QTc. The child would have an ECG before and usually around 7 to 10 days after starting flecainide. Some paediatric cardiologists will also arrange a flecainide blood level. The ECG can be performed at the specialist paediatric cardiology hospital or in a local hospital or by a general practitioner and sent to the paediatric cardiologist for review. Alternatively, if you wished to monitor the ECG more closely, such as for initiating sotalol, you could issue the patients with a Cardia mobile 6-lead ECG monitor and ask them to download an ECG using a mobile phone. For example, you could ask the patient to download an ECG for review before each dose of medication. The potential cost savings are highlighted in this paper from the Journal of the American Pharmacists Association that evaluated a program for outpatient sotalol loading with physician and pharmacist monitoring. 12 patients completed outpatient initiation of sotalol, uploading ECGs for all 3 days. There were no adverse events, and on average, outpatient initiation cost around 8.5 times less than inpatient initiation. So in summary, there is no doubt that Class 1 and Class 3 antiarrhythmics may be proarrhythmic. But this debate is not about whether the drugs are proarrhythmic. It is about whether Class 1 and 3 antiarrhythmics should only be started as inpatient. Many are started as inpatient because they are used for patients with acute or intractable arrhythmias or for patients with rare channelopathies where response to the drugs is unpredictable. However, Almost 30 years of clinical and published experience show that patients with structurally normal hearts and paroxysmal SVT do not need to be an inpatient to start the oral class 1 and 3 antiarrhythmics flecainide and sotalol. The important factor is to monitor the ECG. This can be done by arranging an outpatient 12-lead ECG, which can be sent to the cardiologist, or by a Cardia 6-lead ECG smartphone device. In summary, it is not the case that class 1 and 3 antiarrhythmic drugs should only be started as an inpatient. Thank you.